Welcome back. Today, we are wrapping up our third and final explainer in our series on referral pathways for the dizzy patient. We spent the last 2 sessions figuring out how to classify vestibular syndromes at the bedside, and then how to match those specific syndromes to the right provider in the Australian healthcare system. But you know what? Finding the right provider is really only half the battle. How you actually communicate with them is what dictates how fast your patient is seen. So in this final explainer, we are going to master the art of the referral letter, how to properly communicate clinical urgency, and your absolutely crucial responsibilities as a GP while the patient waits. Let's get into it.
First, I want to put you right at the triage desk of a slammed specialty clinic. A registrar picks up your referral letter. They have roughly 30 seconds to read it, digest the entire clinical picture, and assign a triage category. That's it, 30 seconds. If your letter is this dense, wandering narrative that buries the lead, your patient is going to be routinely undercategorized. Your reader needs to find the answers to 3 specific questions immediately in line 1. What is the problem? What have you tried? And what do you want from me? If you bury those answers, a patient who actually needs timely intervention might wind up waiting 6 or maybe even 8 months on a wait list for the completely wrong outcome. And nobody wants that.
Okay, let's dive right into Section 1, the anatomy of a good letter, and its 8 crucial components.
Look, writing a highly effective referral letter isn't about writing more, it's about writing with structure. Let's deconstruct the first 4 components. Number 1, and this is absolutely non-negotiable for a good triage outcome, is stating your specific clinical question right in line 1. Are you looking for a diagnosis, an intervention, a second opinion, or specific testing? Remember, the aim of a referral isn't just to confirm the patient is dizzy. It's to answer a question you can't answer yourself in primary care. Number 2 is your TiTrATE history. So the timing, triggers, and targeted exam findings, and definitely include the date of the first episode. Number 3, detail your bedside exam. Mention your Hintz exam, your Dix-Hallpike, orthostatic blood pressure, and any nystagmus you saw. Finally, number 4, state your working differential diagnosis alongside the next most likely options. Doing this proves to the triage clinician that you've applied a rigorous, structured framework.
All right, moving on to the final 4 components. Number 5, clearly outline any hearing and otological features, things like tinnitus or oral fullness. And please, attach a recent audiogram if there is any hearing change. Number 6 is a huge one. Detail the trials and investigations to date. Have you attempted an Epley maneuver? Have you tried prophylactic medications? Attach those formal MRI reports and relevant blood results. Documenting all of this proves to the specialist that you've already done the critical first-line heavy lifting. Number 7 is the functional impact of the dizziness, which we'll talk more about in a second. And number 8, firmly outline a patient's expectations, including whether they're willing to do telehealth or travel for care.
Moving right along to Section 2, Communicating Urgency. You have to match the channel to the tier.
Clinical severity has to dictate your actual method of communication. Now, what's really interesting here is how this maps a stark, color-coded mental model directly to specific clinical conditions. It completely removes the guesswork from how you escalate a presentation.
Let's break down the practical action for each tier. Tier 1, that's your red light, same-day emergency. Think acute vestibular syndrome with central Hintz, sudden sensorineural hearing loss with vertigo, or a suspected posterior circulation stroke. These demand an immediate phone call. Sending a routine written letter for a Tier 1 event is, frankly, inadequate and dangerous. Tier 2 is within 1 week. So things like an asymmetric sensorineural hearing loss, a suspected schwannoma, or severe Meniere's. This needs a phone call or an explicitly flagged urgent letter. Tier 3 is within 1 month, usually for refractory issues or diagnostic uncertainty, handled with a routine letter that's flagged as urgent. And finally, Tier 4 is your standard routine referral for stable chronic dizziness or an ongoing rehab need.
Which brings us to Section 3, Functional Impact, or what I like to call the hidden triage drivers. So, you've stated your question, you've chosen the right channel, but let's look at a fascinating reality of the triage desk. A patient's functional impact often escalates their triage category way faster than the symptom of dizziness itself. Think about it. If you document a patient's inability to work, current driving restrictions against Osroads requirements, or a history of recurrent falls, you are giving that triage clinician a tangible, real-world reason to prioritize the referral. Furthermore, noting their mood, anxiety, or avoidance patterns paints a complete picture of a human being whose life is actively being disrupted. That moves them up the list. And now, Section 4, Closing the Loop. Your responsibility as a GP during the wait. So the perfect letter is sent via the correct urgency channel. Time to wash our hands of it, right? Absolutely not.
The GP's job isn't finished the moment that referral goes out. Step 1 is sending the referral, but Step 2 is a hard, mandatory checkpoint at 4 to 6 weeks. And this brilliantly illustrates why. A patient's functional and emotional state will measurably deteriorate during long specialty waits. You have to book this review, regardless of how long the receiving clinician's wait list is. You are their safety net while they wait in limbo.
So what exactly are you doing at this 4 to 6 week checkpoint? Let's walk through it. First, you must revisit and carefully document your driving advice at every single review. Don't skip this. Second, assess their falls risk. Talk about home safety, appropriate footwear, maybe walking aids, and check their vitamin D if indicated. Third, explicitly screen their mood. Actually use a tool like the PHQ-2 and refer them out to psychology if their anxiety or avoidance behaviors are starting to snowball. You are actively managing them while they wait for the specialist.
We have covered a massive amount of ground across these 3 explainers, but if you take away just one guiding philosophy from everything we've discussed about the dizzy patient, let it be this: refer fewer patients more selectively. Match the syndrome to the provider. State the question, close the loop. If you follow this structure, you're going to fundamentally change the trajectory of vestibular care for your patients. It's a real game changer.
I really hope this structured approach empowers you the next time a dizzy patient walks into your clinic. Don't let your clinical questions get buried, and always match your communication channel to the true urgency of the presentation. Thank you so much for watching. To explore more about dizziness, vertigo, and imbalance topics, and to access some great clinician resources, be sure to visit AustralianDizzinessClinics.com. I'll leave you with this final thought. When your next dizzy patient walks through your door, will your referral letter fast-track their recovery or accidentally sentence them to a 6-month waitlist? The choice is yours.